This is Rachel. They're an 18-year-old non-binary patient with a frontal headache. This video will show how to integrate and apply the knowledge required to complete an advanced neurological assessment. This will include physical examination, patient history, and the use of the point-of-care ultrasound in the assistance in the neurological examination. It will justify the use of point-of-care ultrasound, specifically transcranial Doppler, in the neurological assessment. It will further discuss the appropriate management plans for the patient, including recommendations for care and ongoing safety netting for optimum patient safety and clinical outcomes. But before we assess, let's start at the beginning. What is the nervous system?
The nervous system is divided into two components, the central nervous system and the peripheral nervous system. The central nervous system consists of the brain and the spinal cord. It is responsible for integrating, processing, and coordinating sensory data and motor commands. Sensory data conveys information about the conditions inside and outside the body, while motor commands control or adjust the activities of the peripheral organs, for example, skeletal muscle. Here's an example. When you stumble, the central nervous system interprets the information about your balance and the position of your limbs. It then coordinates the recovery by sending motor commands to the appropriate skeletal muscles. Hopefully. The peripheral nervous system is made up of cranial nerves, which are connected to the brain, spinal nerves, which are attached to the spinal cord, and delivers sensory information to the central nervous system. It carries out motor commands to peripheral tissues and systems. Therefore, to identify potential underlying pathology, we will need to assess these systems. There are 12 pairs of cranial nerves, which are named relating to their appearance or function. Each cranial nerve is attached near the associated sensory or motor nuclei. These nerves are classified as sensory, motor, or mixed. Assessment of the cranial nerves is important as it can provide clues to underlying CNS problems. This will be discussed in detail throughout the video. To assist in the understanding of the transcranial Doppler, a brief overview of the blood supply of the brain will be provided. The brain receives blood from two sources, the internal carotid arteries and the vertebral arteries. The internal carotid arteries branch to form two major cerebral arteries, the anterior and middle cerebral artery. The right and left vertebral arteries come together to form the midline basilar artery. The basilar artery joins the blood supply from the internal carotids in an arterial ring at the base of the brain called the circle of Willis. But now it's time to begin our assessment. Firstly, the primary survey should be conducted. This is a 60 to 90-second assessment that allows for the identification of life-threatening conditions. This is followed by the secondary survey that identifies the reason for the patient's current complaint, any general history taking, the sample assessment, and a vital signs survey. Their vital signs were as followed. Many neurological conditions can affect the nervous system. This includes headaches, including the one that our patient currently presents with. So therefore, it's time to assess the nervous system via a comprehensive neurological assessment. The neurological examination is an assessment tool to determine a patient's neurological function. It is beneficial as it allows for the localization of neurological diseases and helps in ruling in or ruling out differential diagnosis. Prior to completing examinations, where possible, clinicians should attempt to create an appropriate environment for examination. This will be a space free from distraction that is well lit and open. Clinicians should first do a general observation of the patient, noting posture and body position, movement at rest, evidence of paralysis, weakness, or involuntary movements, and level of consciousness. When conducting neurological history taking, clinicians should be wary of particular red flags. This includes a morning headaches, in which patients wake in the morning with a headache. An occipital morning headache may be indicative of raised ICP caused by a tumour, a lesion, or systemic hypertension. A morning headache in the frontal region is likely as a result of a migraine or sinusitis. Clinicians may also be able to link this to toxicity, such as carbon monoxide poisoning. Clinicians should hold great concern around the first and worst headache as described by the patient. If someone who is not prone to headaches complained of the first and worst headache of their life, this could have serious implications including vascular tumours or expanding and/or ruptured aneurysms. A thunderclap headache, described as a sudden onset, as if being hit with a hammer, is a significant red flag, as this is often linked to ruptured intracranial aneurysms. Recent trauma to the head from sporting injuries or falls should also be considered a red flag. The patient identified no to the above flags. A complete neurological examination should contain the assessment of cognition, cranial nerves, motor and sensory input, gait, and reflexes. Due to cognition assessments being commonplace in the pre-hospital setting, this video will not go into depth on the Glasgow Coma Scale or a mental status examination. However, clinicians should use these tools when conducting a comprehensive neurological assessment. The olfactory nerve is the first cranial nerve and is a sensory nerve that is used by the assessment of smell. The patient is instructed to close their eyes and mouth and obstruct one of the nostrils using a finger. A 30 cm ruler is placed downwards with the 0 mark at the patient's nose. Starting from the 30 cm mark, the alcohol pad is introduced and moved 1 cm closer to the nose until the alcohol scent is perceived. The distance between the alcohol pad and the nose is recorded. Abnormalities to this cranial nerve may be as a result of lesions to the base of skull, infections, allergies, or nasal polyps. If in the incidence of trauma, it may be as a result of fraction of the cribriform plate. Cranial 2, the optic nerve, is a sensory nerve. Assessment of the optic nerve function includes tests for visual fields and visual acuity. Have the patient close their left or right eye. Close your right eye and stretch your arms forward to the sides of your hands so they're about 130 and 1030, just barely visible in your peripheral vision. They should be the same distance from you and the patient. Hold the index finger of each hand extended. Quickly flick the finger on either the right or left or both hands and ask the patient to identify where the movement occurs while looking at both hands. Ask the patient to identify where the movement occurs while looking directly at your nose. Move your hands roughly to 430 and 730 and test again. This should then be repeated with the left. Abnormalities to these assessments can be indicative of pressure from a pituitary tumor and can present with monoocular blindness and visual field cuts. The pupillary light reflex can be tested by shining a light directly into the eye. The room illumination should be reduced as much as possible. A pen light should be shone on the bridge of the patient's nose that you can see both pupils without directing light into either of them. Check that pupils are the same size. Now move the pen light so that it is directly shining on the right pupil, and check to see that both pupils have constricted. Next, move the pen light to the bridge of the nose so that both pupils can dilate. Repeat this with the opposite eye. A dilated pupil that is unresponsive to light may indicate a lesion on the efferent limb of the pathway, while the constricted pupil can pinpoint to a lesion on the cervical sympathetic chain. Abnormalities like papillar edema or retinal hemorrhage are red flags and can point to life-threatening conditions like increased intracranial pressure and subarachnoid hemorrhage. Cranial nerves 3, 4, and 6 are the nerves for extraocular muscle movement. They control eye movement. Assessment of these involves drawing an invisible H in front of a patient and asking the patient to follow them with their eyes. While conducting the assessment, have the patient fixate on your finger, held about 2 feet away. Note abnormal findings present, such as disconjointed gaze, diplopia or double vision, and nystagmus. Nystagmus can be an indication of central nervous system issues such as multiple sclerosis, head injuries, or brain tumors. Compression of the third cranial nerve by aneurysm of the posterior communicating artery can lead to a dilated pupil, ptosis, also referred to as eyelid drooping, and abnormal eye movements. Involvement of the sixth cranial nerve can result in lateral rectus palsy, also referred to as cross-eyed. This can be a sign of increased intracranial pressure due to cerebral aneurysms, lesions, intracranial inflammation, or due to vascular disease. Cranial nerve 5, or the trigeminal nerve, supplies sensation to the face, with the motor component being responsible for mastication. Assessment of this nerve involves touching the right of the patient's forehead, cheek, and chin, before repeating the procedure on the opposite side.
The patient should be then asked to clench their jaw and open it against pressure.
A corneal reflex is usually reserved for patients in a comatose state. If abnormalities are noted to any of the following, it is likely indicative of a localized lesion affecting the trigeminal nerve. The cranial nerve, or cranial nerve 7, is a mixed motor and sensory nerve. It supplies the muscles of the face and the taste of the tongue. Assessment of this nerve involves asking the patient to move their facial muscles by specifically wording them to raise their eyebrows, close their eyes tightly, and blow up their cheeks. Unilateral weakness to one side of the face is indicative of either a peripheral lesion or damage to facial nuclei, such as Bell's palsy. The sensory component of taste should be tested on the anterior two-thirds of the tongue. A sweet, sour, or salty solution should be applied to a cotton swab and placed on either side of the tongue. Cranial nerve 8 supplies functions in hearing and equilibrium. Gross assessment of this function can be done by rubbing fingers together close to the ear and asking patient if they can hear. If a hearing deficit is noticed, a Weber and Rene test can differentiate hearing loss. This, however, will not be discussed further in this video. The glossopharyngeal and vagus nerves are cranial nerves 9 and 10. They innervate the pharynx and the posterior third of the tongue. Assessment of these nerves include asking the patient to swallow some water and observe for coughing or gurgling speech. This may indicate the weakness of muscles involved in swallowing. Ask the patient to open their mouth and say ah, and observe for palatal arch asymmetry. The deviation of the uvula to one side may indicate a vagal nerve lesion on the opposite side. The spinal accessory nerve, or cranial nerve 11, innervates the muscles of the thorax, back, and shoulders. Assessment involves asking the patient to turn their head to the side against resistance and shrug their shoulders. Weakness of these muscles may indicate involvement of the 11th cranial nerve. The hypoglossal nerve, or cranial nerve 12, innervates the motor component of the tongue. Assess the tongue in a relaxed position inside the mouth. Ask the patient to stick their tongue out and deviate it from side to side. Weakness may be indicative of a lesion on the same side, and fasciculation of a resting tongue may indicate a lower motor neuron involvement. Ask the patient to walk 10 meters. Their gait should be smooth, rhythmic, and effortless. Have the patient then walk on their tippy toes, followed by a tandem walk placing one foot directly in front of the other. Unsteadiness with any of these maneuvers or asymmetry should be recorded. Ataxic gait lacks coordination with instability. Clinicians should discuss with patients associated vertigo or nausea when mobilizing. An inability to tandem walk is particularly sensitive to upper motor neuron lesions such as multiple sclerosis or acute cerebellar dysfunction, for example, intoxication. For assessment of the pronated drift, have the patient stretch their arms out so that they are level and fully extended with their palms facing straight up. Then have them close their eyes. Watch for 5 to 10 seconds to see if either arm tends to pronate or drift downwards. This is also the opportunity to assess if the patient is swaying or needs support when sitting unsupported. The motor exam should include assessment of range of motion and muscle strength. This can be done in both the upper and lower extremities. For each movement, place the limb near its middle range and ask the patient to resist against you trying to move the limb from the position. For grading of strength, the 0 to 5 Medical Research Council scale may be used to assist clinicians. If an abnormality is identified, clinicians may wish to perform a more localized assessment.
Bend this knee. Perfect. And down. Bend this knee. And down. Lift this leg up. Lovely. And the other one. Perfect. Push against my hands and pull up.
Coordination may also be assessed using the finger to nose testing. Ask the patient to use the tip of their index finger to touch the tip of your index finger and then the tip of their nose. The assessor should move their finger to several different positions during testing. This should then be repeated on the opposite arm. Observe for accuracy. Deep tendon reflex testing evaluates afferent nerves, synaptic connections within the spinal cord, and motor nerves. This allows for the assessment of lower motor neuron lesions with depressed reflexes and upper motor neuron lesions with increased reflexes. Clinicians should be observing for spasticity, also referred to as clonus, which is a self-sustained oscillating motion. This is achieved when clinicians hyperflex and stretch a muscle and apply a sudden jerking force, such as on the ankle or patella. The Babinski reflex or the plantar reflex is assessed by taking a blunt object, i.e., the tip of a pen, and tracing from the heel in an arch-like motion to the greater toe. A positive Babinski reflex will result in the dorsal flexion of the greater toe. This is indicative of a lower motor neuron lesion. The sensory examination involves assessment of patient-reported alterations to sensation. Clinicians are able to assess for sensation via touch, pain, temperature, and vibration. A location and pattern of sensory defects is helpful in the localization of potential underlying pathology. To test for touch, have the patient close their eyes and tell you whether you are touching their left hand, right hand, or both simultaneously. Repeat this several times over both upper and lower extremities. To assess for pain, explain to the patient that you will be touching them with either the dull or the sharp end of a safety pin. Ask the patient to close their eyes and lightly touch with either the dull or sharp end of the pin, asking the patient to identify whether there is a dull or sharp pain. Repeat this bilaterally to upper and lower extremities. Meningeal symptoms should be assessed. Pain and rigidity on passive flexion of the neck is indicative of a meningeal symptom. A positive Koenig sign notes pain on passive extension of the knee while the hip is in a flex position. A positive Brudzinski sign is where passive flexion of the neck causes a reflex of knee flexion when a patient is in the supine position. Causes of meningeal irritation can include CNS infections such as meningitis and subarachnoid hemorrhage. Slight deviation on the tandem walk was identified. There were nil other abnormalities noted during this assessment. Transcranial Doppler ultrasound can be complementary to the comprehensive neurological assessment. It provides accurate real-time information, is portable, low cost, and non-invasive. Firstly, have the patient lie in a supine position. The transcranial Doppler assesses the circle of Willis. With this technique, ultrasound waves are sent through the tissues of the skull and reflect off blood cells in the vessels, allowing the interpreter to detect the speed and direction of blood flow. By measuring this flow velocity, the clinician assesses for changes in flow that could indicate areas of stenosis, acute ischemia, vasospasm, subarachnoid hemorrhages, or increased ICP. There are 3 windows of cranial access, however, the temporal window provides the best view. The Doppler probe should be placed at the patient's temples with a small amount of gel. The Doppler should be positioned to direct the ultrasound waves towards the blood vessels being examined. Using a 2 MHz pulse wave Doppler probe, waves are emitted from the probe, which is reflected by the flowing red blood cells back to the receiver. Blood flow velocity is calculated according to the Doppler effect, and cerebral blood flow is reflected by indicators such as blood flow velocity and pulse index. Doppler sample volume depth should be placed where it is likely to find the bifurcation of the internal carotid artery to the middle cerebral artery and the anterior cerebral artery, as this is an area rich with vascular flow. Turning on the color flow will then allow for the identification of cerebral anatomy. Blood flow velocity is one of the main criteria for judging the pathophysiological state of the blood vessels and is usually measured in centimeters per second. Spectral waveforms allow for this assessment. Studies conducted by Ali 2021 and Zhu et al. 2019 noted that transcranial Doppler may be used in the assessment of subarachnoid hemorrhage. Cerebral vasospasm after subarachnoid hemorrhage is well known, and it leads to a decrease in the diameter of the blood vessels. This is detected by the transcranial Doppler monitoring through change in cerebral blood flow velocity. Statistics show that up to 70% of subarachnoid hemorrhage patients have cerebral vasospasm. Specifically for vasospasm, a velocity between 90 centimeters per second and 120 centimeters per second is thought to indicate mild vasospasm, while 120 to 220 centimeters per second is considered moderate to severe, with greater than 220 being considered critical. This may assist clinicians with the potential identification of vasospasm as a result of underlying cranial pathology. Primary and secondary brain injuries as a result of TBI can increase ICP. In the setting of a significant abnormal increase to ICP, the transcranial Doppler waveform will change considerably, specifically in the setting of significant ICP greater than 20 to 30 milligrams of mercury. This is reflected with a sharp sloping waveform and an increased pulse index. Pulsatory index is an indicator of the amount of vascular resistance and is used as an indirect evaluation of the intracranial pressure. However, this can be limited when assessing small increases to ICP. Studies conducted by Bankol et al. 2022 found that transcranial Doppler assisted in the clinical decision making in TBIs and therefore could be assumed beneficial when used in conjunction with the neurological assessment. This may allow for further support in the use of neuroprotective management such as appropriate oxygenation, maintenance of blood pressure, elevation of the head, and temperature control. Studies conducted by Gao et al. 2022 also noted that transcranial Doppler was noted to be comparable when assessing for ischemic cerebral disease. It has also shown promise in identification of large vessel occlusions. Further, this point of care device may assist clinicians in identifying transportation to appropriate receiving facilities. The patient's spectral waveform, blood velocity, and pulse index were as followed. If the patient shows no abnormalities during the comprehensive neurological assessment nor on the transcranial Doppler, it is likely they are suffering a tension type headache. This can be a result of fatigue, stress, dehydration, or facial muscle contraction. Tension type headaches is characterized by frequency and by a mild to moderate headache that is not associated with the typical debilitating migraine symptoms of nausea, vomiting, photophobia, or an aura. It is unlikely to be a cluster headache as the pain is not unilateral. It should, however, be noted that there was a slight variation to the patient's tandem walk. This, in conjunction with a headache, may provide certain red flags for MS, despite the patient falling slightly outside the age bracket. Further, the transcranial Doppler would provide minimal assistance in this identification. Due to diagnostic uncertainty surrounding headaches, this patient will need ongoing clinical surveillance to allow for identification of physiological changes over time. Clinicians may wish to provide simple analgesia and accompanying environment in the interim. Identification of these changes may require further investigation, such as a CT. Therefore, this patient should be transported to hospital.